Okay, so has everybody met Zach since he's been here? Yep. So this is Zach Lau. He graduates from Drake in May with his PharmD
And MBA.
and MBA at the same time. And he will be done on Friday. So go ahead, Zach.
Well, it's
I
flown by here.
will let you introduce your topic here.
Like Deanne said, my name is Zach Law, and I am a P4 pharmacy student at Drake University. And today, my topic today I'm going to be talking about is treatment and prophylactic uses of proton pump inhibitors and the consequences of chronic PPI use. All right. Today, I'm going to be talking about 4 different objectives. First of all, I'm going to review the mechanism of action of PPIs. I'm going to list the appropriate treatment and prophylactic indications for PPIs. We're going to recognize the adverse effects of chronic PPI use. And finally, we're going to establish evidence-based duration of therapy for prophylactic and therapy of PPIs. First of all, a little background about proton pump inhibitors. First of all, the long-term use is becoming increasingly common among prescribers, prescribing this, and even over-the-counter use among patients. A lot of times without even proper indication. Secondly, regardless of both short and long-term effects, in patients with GERD, studies consistently have shown that PPIs are being overprescribed in both primary and secondary care, and that PPIs are being prescribed for inappropriate indications. This is both by patients overusing it over the counter for personal use, or using it daily when it should be just as needed, or even just for indications that a prescriber is prescribing. No offense, doctor.
Pass them.
I was just being general. Don't want the birthday to go to his head too much. Next, the mechanism of action. As you probably all know a little bit, the PPIs suppress gastric basal and stimulate acid secretions that inhibit the partial cell hydrogen and potassium ATP pump in the stomach and the gut. Moving on to the prophylactic and treatment indications for PPIs, there's both FDA labeled and not labeled uses, of course, just like most other things. Some of these were more surprising than others just because some of these we see in our everyday lives, but they're the non-FDA approved uses. So first of all, with FDA approved uses, we have the H. pylori, gastrointestinal tract infections, induced ulcers, erosive esophagitis associated with a GERD, gastric hypersecretions, gastric ulcers, heartburn, and pathological hypersecretion conditions. Otherwise, one of those, for example, is the Zollinger-Ellison syndrome, which is a rare condition in which one or more tumors in your form in your pancreas or upper part of the small intestine. Now moving on to the non-FDA approved uses, NSAID-induced peptic ulcer prophylaxis and treatment is one of the major off-label uses. And some of the different risk factors of this are being older than 65, history of ulcers with or without bleeding, concomitant use of anticoagulants, steroids, or having a severe comorbidities, or using high-dose NSAIDs or prolonged NSAID use. Additionally, there's duodenal ulcer disease, dyspepsia, esophageal stricture, refractory GERD, and continuing on with giant duodenal ulcers, H. pylori eradication, nocturnal hyperchlorhydria, prevention of rebleeding and peptic ulcer bleeds, and stress ulcer prophylaxis in critically ill patients. For the stress ulcer prophylaxis, if you turn to the final page in this packet, I have a little addendum on there that you can see different indications for stress ulcer prophylaxis, especially in the critically ill and ICU patients. Partially this applies here, other times it applies definitely to more places downtown, but some of these still apply to some of our patients here. This has been the established different indications for stress ulcer prophylaxis, especially among critically ill and ICU patients. I'm not necessarily going to touch on that anymore, but definitely good guidelines to recognize here moving forward with everything. Tend to see that on every single rotation no matter where I'm at, so that's always a good, important one to see in line there. Moving on to the adverse effects of chronic PPI use. We're going to start with hypocalcemia. The risk of fractures is increased with longer duration of PPIs, especially in patients that are on high dose, which high dose is defined as greater than 1.5 doses per day. The risk in self-treatment in OTCs, as I was already mentioning, with patients using it just by the fact of seeing it over the counter and seeing that they have GERD or acid reflux that they want to use it for. I've seen studies that recommend pharmacists keeping it behind the counter, but that is, I think, too far of a reaching of a step to make that even obtainable or realistic. I've seen, from my research, I've seen no effect on bone mineral density, and the short-term use of less than 1 year is still associated with similar fracture risk compared with long-term PPI use of longer than 1 year. Next, with hypomagnesemia, this affects the underlying biological mechanism, but it's still not known what the actual cause of the interaction between PPIs and this is. Moving on to vitamin B12 deficiency. In the diet, vitamin B12 is protein bound and requires acid to be activated and digested, but with the acid being suppressed, it's not able to be absorbed as appropriately. And same with iron deficiency. Patients with hereditary hemochromatosis receiving long-term PPI therapy had significant reduction in the volume of blood that must be had to be removed and maintained with acceptable ferritin levels. Moving on to more adverse effects of chronic PPI use. There's also acid rebound. Studies have shown that with different treatments with PPIs for more than 8 weeks leads to temporary increased capacity to secrete acid after discontinuation of treatment. This rebound phenomenon suggests that long-term elevated PPI use elevates the gastric pH, which stimulates compensatory pH and gastrin release. Next is neoplasia. The consistent elevation of the pH in the stomach caused by long-term PPI use causes, like I said, the increase in gastrin secretion, resulting in an increased plasma gastrin concentration. And because of the trophic effects of gastrin, there have been concerns that long-term treatment of PPIs, especially over 12 months, can cause gastric polyps, gastric cancer, and different colorectal cancers, which have been some have been actually studied and some have just been only shown in different case studies. There's also a risk of C. diff, which is a big popular one that the FDA is pushing out right now, making a public statement about it, which they have made it a labeled change for several PPIs to include the warnings of increased Clostridioides difficile, formerly known as Clostridium difficile, associated diarrhea and fractures also associated with that, not necessarily in the same breath there. And finally, with acute interstitial nephritis, there's a high instance, but it's not necessarily statistically significant among the studies that I've been looking at. Next, moving on to evidence-based duration of therapy and prophylaxis for PPI use. PPI use is approved for a duration of 2 to 12 weeks, depending on the complication and severity of different conditions. The three different PPIs, omeprazole, lansoprazole, and esomeprazole, have over-the-counter approval for short-term use up to 14 days only, which a lot of times this is overstepped by quite a large margin. And finally, avoid scheduled use of greater than 8 weeks unless there is a high-risk patient, for example, a patient on oral corticosteroids or chronic NSAID use, or a patient that has erosive esophagitis, Barrett's esophagus, pathological hypersecretory conditions, or they have demonstrated a need for maintenance treatment, whether due to failure or a drug discontinuation or failure of H2 blockers. And finally, they have recommended the duration of 8 to 16 weeks initially, and to not step over that for those kind of conditions. Continuing on with the different durations of treatment. The optimal duration of PPI varies based on the initial ulcer size in patients with ulcers, but patients with endoscopic submucosal dissection, otherwise known as ESD, induced artificial ulcers of greater than 40 millimeters, which is also known as a large ulcer, should be treated with only 8 weeks of course of PPIs. This study looked at 30 milligrams of lansoprazole daily, specifically for this one. H. pylori associated peptic ulcers should be treated with 7 days of treatment of PPIs plus 2 antibiotics, and this heals more than 90% of ulcers among these patients. NSAID-induced peptic ulcers should be treated only for 8 weeks. And finally, GERD should be treated for no more than 8 weeks as well. You're seeing a trend among 8 weeks here. Finally, with my conclusion, based on the existing evidence, the benefits of PPI's treatment outweighs potential risk factors for a large majority of patients, especially for those with PPI based on the relevant indication. The concern of complications should primarily be directed for elderly, malnourished patients with significant comorbidities. In the population, an increased risk of enteric infections, fractures, and nutritional deficiencies might have clinical consequences that should be led to careful evaluation of the indication for PPI treatment. And finally, the use of PPIs should be used more judiciously and use a minimum duration and dose for the given indication. And those are all my different references. What questions do you have for me?
I got one. So back here, talked about the colorectal cancer.
Yes.
I think I understood what you're saying. I'm not sure.
Mm-hmm.
So they saw some on case studies, or there was a significant increase.
So there was an increase in statistically increase in these different cancers, but the specific different colorectal cancers, some have been only seen in case studies versus in the actual large studies that have been going on. Specifically, the colorectal cancer, that one specifically has only been shown a few times in some different case studies, but when they did the large populations studies, it wasn't able to be recognized, especially statistically.
There's statistical significance there. Just that they occasionally saw some.
Yes. Yep. There's definitely more incidents among case studies, just by the nature of case studies. It's more to shine light onto obscure things, but that you won't necessarily see among your daily life patients.
So Zach, on the, were you talking about the risk of fractures?
Yes.
So, just so I'm clear, despite the fact that there's no decrease in bone mineral density with long-term use, we still have an increase in fractures.
Yes.
That's kind of interesting.
Yes. Yeah, so there definitely has been conflicting studies revolving that, but it seems like in the last year and a half, it looks like they've for sure said that there is an increased risk of fractures. I was looking at some studies from 2013, and they were saying that there's no increase in specifically hip fractures among these patients, which I found kind of interesting, especially because this next study that would happen in 2017 that I was looking at directly contradicted that. So it looks like there definitely is more room for studies, especially when there's such opposite sides of the spectrum with this fractures, but I would say yes, it does increase your risk of fractures.
So some studies said yes, some studies
Yes.
said no.
More recent ones have said yes.
And then on the FDA warning, so we're not talking about a
not
black
a
box
black
warning,
box,
but just addition to the warning section of the labeling, and it will include. Is it out? When did the FDA do that?
So that study I was looking at that mentioned that was published in September, I believe. So it was a very recent thing. I didn't see any changes in any labels that I looked at personally yet, but doesn't mean that they will still be rolled out, because it looked like it was a recent change that I saw.
So the FDA does intend to add it to the warnings. So it would be the increased risk of fractures.
Increased risk of fractures and increased C. diff. risk.
Okay.
Yes. And a lot of places I was looking at was still saying Clostridium versus Clostridioids, but very minor thing with the new 2018 guidelines that came out in February for that, but it was more of a class thing.
So what's the suggested mechanism behind PPIs increasing the risk of C. diff? I mean, is there something to do with decreased acid production and increasing the risk of the growth of that particular bacteria, or what is it?
I did not see anything specifically about that. I can definitely get back to you on this, but I did not see any specific data suggesting with any confidence that somehow you would more likely show that you have the flora growing in you versus a normal patient that's not on chronic PPI use, but I can definitely look into that further and get back to you.
Yeah, it'd be interesting what the theory is of that connection,
Mhm.
you know?
Yeah.
I mean, we know it's there,
Yes.
but why does that
Yeah, it's
occur?
not an obvious like clicks in your head kind of interaction, especially since that's a pathogen that you would hope you don't have specifically in your gut, but if it's just pronounced by having chronic PPI use, yeah, you
And
might
the-
want to go down there. That doesn't sound fun for any of us.
Then on the non-FDA approved uses,
Yes.
so you have NSAID-induced peptic ulcer prophylaxis and treatment.
Mhm.
So are there any guidelines out there? Because this looks like that was listed as a gastroenterology journal. So are there any guidelines for under which conditions you should put somebody on a PPI who's on NSAIDs?
Of what I saw for any guidelines, I did not see any specific conditions, but I saw there's more likelihood among patients greater than 65, patients that are on chronic anticoagulant or steroid use, or chronic or higher doses of NSAIDs and other comorbidities. But I didn't see any other specific guidelines about duration or anything like that, unfortunately.
So there's not anything out there from some gastroenterology society that says if your patient is 70 and they're on an NSAID and they're also on Plavix, they should be on a PPI prophylactically. You didn't find anything like that. Okay.
With that patient that you described right there, it sounds like they definitely would be based off of prescribing habits, but I haven't seen any specific guidelines around that.
Because it would be nice if there was something that straightforward. Because when you think about that patient I just described, how many of those patients are out there? I mean, a boatload.
Yes.
You know, so it'd be nice if there was some evidence that clearly stated, yes, you're a candidate, or no, you're not. You know, do the benefits of PPI prophylaxis outweigh the risks of chronic use? But
Yeah, and what I've seen is that a lot of these adverse effects, or especially with in terms of ulcers, that usually only happen in 1 to 2% of patients. So it's not like it's still a very large majority of patients, but it's still a definite thing you should watch out for and be aware of.
If I understood correctly then, it looks like PPI use, FDA approved, was mainly for ulcer disease.
Correct.
Not really for anything else,
Mhm.
just ulcer disease.
Yeah.
Obviously, we're using, and probably most PPI use is not for ulcer disease. So is that what that first conclusion, if I understand that, so it says, based on existing evidence, the benefits outweigh the potential risk in the large majority of patients. So what they're saying there is, even though we're using it maybe more than we should, sometimes the benefits outweigh the risks involved. Keep on doing it.
Yes.
Now, my other question then is, so there are some risks involved.
Yes.
Anything in there about the H2 antagonists, Tagamet, Pepcid, Zantac, stuff like that, does that have the same risk? It's also acid suppressing, or is that a quote okay thing to go to that alternative? Because I have a lot of people, they try stopping their Prilosec, and within 3 days, they're hurting again.
Yes.
They're going back to the Prilosec, I can tell you, whether I prescribe it or not.
Yeah.
So, because they're hurting. I've tried to encourage them to try some Zantac. Some of them say, yes, Zantac does okay. Have I just changed, but have I really helped them any? I mean, are they still going to have these same problems? Is it just because of acid suppression, or is Zantac magically better in that it won't cause the fracture risk and stuff like that? Did you happen, I mean, that's kind of off the wall. Did you happen to see anything like
So,
that?
from what I saw, I wouldn't say it's a complete only PPI is risk. It sounds like there is some crossover between the two different classes. To what percentage and what occurrence rate it happens, I cannot say with any confidence. But it does look like there is some crossover, but it did not sound like the fact that there's a risk of fractures or the risk of C. diff does not sound like people should start running out to get the newest ranitidine or the newest salt form of an H2 blocker. It seems like PPIs will still be readily used for these kind of conditions. Like I said, it's usually only a 1 to 2% chance of these things happening, but it still has great great potential for problems and adverse effects down the road if one of these things did happen. But from what my interpretation of my conclusion was that as long as it's within the guidelines of like the specifically like for an approved indication and around the 8-week mark as like the maximum, like you're saying, there's always gonna be some people that want to still be on it no matter what. It shouldn't be as much of a problem as long as it's held within those boundaries. But it's good to say what's on paper versus what's actually for the patient to be able to do when we're talking to them. So.
And I should mention that when I assigned this topic, I didn't ask Zach to look at long-term use of H2RAs. So,
Right, I knew that was all. But
yeah.
see, that's where I'm getting
But-
letters from insurance companies. So-and-so has been on, omeprazole for, quote, more than 8 weeks, and, they suggest the alternative of trying an H2 antagonist. Okay, but have I really
Is that gonna
helped?
change
Have I really
anything?
changed anything?
Right.
I mean, is that just jumping from the pot to the fire, the pot to the kettle? Have I really changed anything or not? And, but then the potential is here, okay, so we've got these studies, the things are FDA approved. Grandma's been on this for a long time. She falls, she breaks her hip. I think I better talk to my lawyer. You've kept them on this medicine way longer than the 8 weeks, and you must be liable for why she has a broken hip and now ends up in the nursing home.
Yeah, we barely touch the tip of the iceberg when it comes to the beer list and criteria of that sort. So that gets into a whole different beast there for different prescribing for different assets.
Provides lots of ammunition for our attorneys.
Yes.
Well, because
Unfortunately.
generally speaking, how many of your patients that are on omeprazole are on it for 8 weeks?
Oh.
I've been on it personally myself for 2 years and never heard anyone say I should have stopped it after 8 weeks.
Yeah, I mean, it's I have people come in all the time, they've seen it on the internet. I mean, this is out there. Okay,
Yeah.
people see it on the internet, shouldn't be on this because of that, whatever. So, well, okay, yeah, you can stop it. But then there are risks in stopping too.
Yes.
Okay, now I have GERD,
Now I feel like jumping.
I have urosity. Eventually, GERD, in my opinion, eventually will lead to Barrett's or esophageal erosion, which will then lead to strictures and or cancer.
Yes.
So there are some definite risks in not stopping the acid suppression. So whether I do it with a H2 antagonist, I guess that's what I was kind of wondering. Are they safer to do it with an H2 antagonist? Now, what I've seen just anecdotally, PPIs work better at suppressing acid than H2 antagonists. Some people can get by with an H2 antagonist, Zantac, but there are some people, I tried the Zantac, it did not work. Prilosec works for me. And so I say, well, you might want to go with your gut. Not how it
No
feels.
pun intended.
That's right. Very good.
Thank you.
Good talk.
Thank you.
Gives
Thanks,
us lots
Zach.
of room for thought.
Yes.
thank you, Zach.
Thank you.